thin air at 1.75 meters altitude. Now this was a 67-year-old man who came in with dyspnea, very severe dyspnea, which was interestingly aggravated when he was in an upright position. When he was lying down, he was doing perfectly fine, but as soon as he got up, he was really dyspneic. And we took a look at him, and he had a normal chest x-ray, and he only had a mild form of chronic obstructive pulmonary disease, where we thought, well, maybe this could not really explain the symptoms he had. So let me show you the echocardiogram of this patient and walk you through to how we solved this case. So this is the patient. Here's his parasternal long axis view. I will give you more gain so you can appreciate the pathology. Well, I think most of you will recognize immediately that there is something wrong with the aorta. Oh yeah, before I forget, you can always ask questions. If you have questions, let me know. I will try to answer them as we go along. You have a button on your screen, and you have a chat window where you can simply enter the text of the question, and I will try to answer the question. Now, the pathology most of you will probably recognize immediately is the aorta here. What you can see here is that the aorta is significantly dilated. This is what we would call an aneurysm. Normally, the width of the aorta is somewhere in the range of maybe 40 or 36 to 40. That's the upper limit, but in this case, it's far beyond that. But how does that have anything to do with dyspnea? Well, maybe it's the left ventricle. This is a 4-chamber view. Now, the patient was very difficult to image, actually, and those were the best images we could get. But still, I guess most of you will appreciate that left ventricular function is rather normal here. But, so the ventricle, could it explain his dyspnea? Well, we'll find out. Another image of the aortic valve, which is a bit thickened. Here is the aortic regurgitation. Now let's turn to diastolic function. We have an E to A ratio here, where the E wave is smaller than the A wave. Typical pattern of impaired relaxation. And now we will turn to the subcostal views. Again, you see the dilated aorta. This is the right ventricle, the left ventricle. Show you another view. Okay, so this is the tricuspid valve somewhere in here, which is pretty compressed actually. This is a short axis view from subcostal, where you can see the inferior vena cava, the right atrium, tricuspid valve, and down here would be the pulmonary artery and the pulmonic valve. And at the center, again, the very large aorta. Let me measure that for you again. Okay, so we get a pretty similar measurement of above 50 millimeters. And finally, here is one more view showing you blood flow here across the tricuspid valve. There is no regurgitation here. And just for the sake of completeness, I'll also give you a kind of a 4 or 5 chamber view, which shows you the mitral valve, just to display that there is no mitral regurgitation or any other pathology of the mitral valve. Now let me go back to my presentation, and the question for you now is, oops, here we go. What do you think is the cause of dyspnea? Remember, the patient has a normal chest x-ray. He has just mild degree of chronic obstructive pulmonary disease. And you should be seeing the question now on your screen, which is, what is the cause of dyspnea? I'll give you a few minutes to answer. Okay, some of you have already answered. Okay, so let's see what the result is, most of you think it's a shunt. Oh, that's interesting. And closely followed by valvular heart disease, probably because of aortic regurgitation that you saw. Some of you also think it still might be the left ventricle which has a problem and causes dyspnea. So a shunt is the problem that you suspect in this case. Well, let me go to the follow-up study of this patient. And what we performed, obviously, was a transesophageal echo. Here you can see a 4-chamber view of the left ventricle. Rather good left ventricle function. There is some degree of left ventricle hypertrophy, and here you can already appreciate the fairly large aortic root and the aneurysm that we also saw from the transthoracic echo. Oops, this is maybe not so good. Here is the interatrial septum. You can see that right here. And this is now a kind of a long axis view through the heart, where we have the interatrial septum here. This is the left atrium, this is the right atrium, the secundum septum, and this part here that is moving around is the primum septum. And what you will probably notice, especially if you performed T studies before, is that there's a wide gap between the secundum and the primum septum. And if we use color, it's clear the patient has a shunt. He has a shunt between the left atrium and the right atrium. In this case, flow is directed bidirectional. You can see flow in both directions depending on the pressure difference between the left and the right atrium. To confirm that, we also performed a contrast study. Let me find, see, this is the width of the gap, which is very large. It's somewhere in the range of almost a centimeter or even more, which is, I mean, if you compare that with an atrial septal defect, this is almost you could call them at least a small until medium-sized atrial septal defect. So fairly large defect here. And you can see the septum moving back and forth. And now I'll give you the contrast study. And whoosh, you see there's a lot of contrast going over from the right heart to the left heart. So what is going on here, and how does that explain his symptoms actually, and why does this patient have this weird kind of symptom with dyspnea, especially if the patient gets up? Here you can see the contrast again. It opacifies almost the entire left atrium. So there is deoxygenated blood which comes in from the right heart to the left heart, and which causes undersaturation. And the interesting thing about this patient was that we tried to perform this contrast study both under the condition of lying in his bed in a recumbent position, and also him sitting up with a T probe in place. And what we could see is was that the shunt got larger when the patient got up. Now, how is that explainable? How can we explain this? Well, now we'll go back again to the aneurysm of the aorta. Well, this is the reason why the shunt is so large. It's simply that this aneurysm of the aorta is distorting the intraatrial septum. Here you can see this very nicely. This is the aorta, and here's the close proximity to the intraatrial septum. And if the patient gets up and the heart axis moves, then there is more pressure, basically, or there's more distortion of the intraatrial septum, and then the gap between the right and the left atrium, the shunt increases, and the patient gets undersaturated. This is a typical form of a pathology, which is also called, let me go to the presentation. Here, platypnea orthodeoxia syndrome. Platypnea means that the dyspnea is stronger in an upright position and relieved in a supine position, while orthodeoxia just simply means that he's undersaturated. This is a disease which is fairly uncommon, but something that you should be aware of, especially if you have a patient who has those kind of symptoms. Now, there are many different causes which can relate to, which can cause a patent foramen ovale, which is there obviously in the first place, to shunt so strongly, and that is usually associated with, for example, the aneurysm that we saw here, sometimes also caused by pulmonary embolism. Very frequently, if we have pneumectomy, and we have an abnormal position of the heart due to pneumectomy, and there are certain abnormalities of the interatrial septum which can also cause platypnea syndrome. So a very rare cause of dyspnea, but something you should think of. How do we treat the patient? Well, the patient obviously needed operation for the aortic aneurysm anyway, and he underwent operation. In addition, the interatrial septum was closed, it was sutured closed, and the patient improved dramatically, and he is doing very fine. He has no symptoms, and he has a very good exercise capacity.